I am so honored today to be interviewing two of my incredible medical advisors, Dr. Akina and Lolly Haverin from Walgreens. Lolly is actually, she leads the clinical pharmacy strategy at Walgreens and brings her expertise in oncology and fertility care. And Dr. Akina will dive deep into endocrinology and her experience, shedding light on complex hormonal topics, including fertility and breast cancer, and understanding why we need to talk about this topic that I feel is not talked about enough. And there's so much behind this. And today we're going to dive deep and really bring forward why treatment can affect your fertility and why having these conversations are so incredibly important. I'm so honored to have you both here today. Lolly, could you introduce yourself just a little bit, and then Dr. Akina?
Sure. So, as you mentioned, Lolly Havern, I am a pharmacist by training. I have been a pharmacist for over 15 years, specializing in both fertility and oncology care. And it's really nice to be here.
So happy to have you. And Dr. Akina?
Hi, I'm Dr. Kenna Abel, and I'm so happy to be here. I am a specialist in reproductive endocrinology and infertility, which is basically a fertility doctor or fertility physician. And I have a passion for oncofertility. I did my fellowship at Northwestern, which is kind of like the birthplace of oncofertility. So this is a topic that is near and dear to my heart.
Well, we're so grateful to have you. And so, both of you, why is having this conversation, fertility preservation, so important for breast cancer patients to know about? Why is this such an important topic?
I think it's such an important conversation because we need to give patients the choice. I understand that not everybody wants children. I think that's very personal decision, but the last thing we want to do is make that choice for the patient. And so if a patient's fertility is going to be affected by their even the current treatment or potentially future treatment, I just think that this is a conversation that is best had before any of that treatment starts. We have so much research that shows that it's such an important quality of life marker, especially as these diagnoses are coming in younger and younger ages. And so really, to me, it's all about having that choice that the patient gets to make, not one that is made for her.
I completely agree. And I think it's important to recognize that part of the reason we have to talk about this more often is because we've actually gotten more effective at treating cancer. And so because we have more patients who are surviving their diagnosis and going on to live this full, complete lives after treatment for breast cancer, it's become more important to now deal with the quality of life issues that we may not have thought were as important when, survival was the only thing we're trying to solve for. And, this has been recognized now by the American Society for Clinical Oncology, saying that patients who are diagnosed with breast cancer should all be informed of their options for fertility preservation.
That's a great question. It's a great topic. Do you think this is actually happening? I mean, I know for myself as a 6-year survivor, I was older, but the time is ticking so fast. So for young patients, do you think that sometimes this conversation gets missed?
It definitely does get missed in some cases. I have to give credit and say that it has improved over the last decade. I've definitely seen more patients being referred by their oncologist versus previously I would see more patients who found out about this option by doing a Google search or talking to like other survivors and being told, oh, you should probably think about freezing your eggs. But I would say that as time has gone on, we've had more and more oncologists who are aware of this, who at least let their patients know about this option before they begin either surgical treatment or chemotherapy, more importantly.
Do you feel that the oncology teams are fully aware of the impact that some of the treatments can actually have? I mean, that's a hard question to ask.
I do think that they are fully aware. The oncologists are aware of the negative impact of their treatments on fertility. I think, again, you have to understand that their perspective is different from the fertility doctor's perspective. My perspective as a fertility doctor is preserving their fertility because I see patients on the other side of this equation who are trying to grow family, status post-cancer treatment, and having all these challenges as a result of the negative impact of their treatment on their fertility. Whereas the oncologist is seeing the patient and their primary thought is, I need to keep this patient alive and I need to do everything I can to keep them alive. And so right now, the conversation is currently shifting where we're having both of these conversations in tandem and realizing that they are not mutually exclusive discussions and that we can both aim to keep the patient alive, have them survive cancer treatment and live happy, full lives afterwards, but also preserve their fertility for after they're done with cancer treatment and also their quality of life for after they're done with cancer treatment as well.
Thank you so much for that.
We are getting better at that conversation, but I still think we have an opportunity. So until every single patient gets counseled, and we know that that's not happening, there's also additional challenges and barriers that an oncologist might have. Like there may not be a fertility clinic in that town. Like they may not be able to access that fertility care quickly enough before the patient starts cancer treatment. So there's really still a lot of limitations. Obviously, things like telehealth are helping, research on oncology drugs are helping. Like there's a lot of things coming, but I still think we do have an opportunity to get those conversations going, and then making sure that the patient has the resources. Then could they have financially afford the treatments and the medications and all of that? So I definitely do think we've gotten better, but there's still ways to go.
And I think a big gap in knowledge is understanding that these treatments don't take a month or months, they take 2 weeks. And I think the more that we're able to discuss with our oncology colleagues and help them understand that this is a short duration of treatment, which I will say that even when I get patients, and usually I'll talk to the oncologist, they're usually still surprised, like, oh, you just need 2 weeks. I'm like, yes, I only need 2 weeks, and then we're good to go. So I think really reinforcing that we're able to turn these patients around within a short period of time, at least in clinics like, that have the resources to move quickly, to provide patients, like you were saying, Lali, with medications, et cetera, so that we can move quickly. These treatments do not cause a significant delay in the start of cancer treatments.
So 2 weeks, can you elaborate? Because I didn't realize that. So what goes on in those 2 weeks?
Yeah, so typically with our oncofertility patients, we try to make the first appointment as all-inclusive as possible. So typically we will, of course, do the full consult, get a full medical history, understand what their cancer treatment plan is, so that we make sure we're keeping that in mind as we plan their treatment going forward. We do an ultrasound at that appointment because that's going to tell us about their ovarian reserve, which is basically the number of eggs they have available each month in their ovaries, which gives us a sense for how many eggs we can expect to get from an egg retrieval cycle and how to dose the medications. We also do a bunch of blood work. We check an anti-Mullerian hormone, which also tells us about their number of eggs. But we also check to make sure that they're not anemic, because a lot of the time, depending on the type of cancer, we want to make sure that they're healthy enough to start to undergo an egg freezing cycle. And then we get the labs that we need in order to start a cycle. So typically that's an estrogen, a progesterone, and LH, and just make sure that if they're able to start meds the next day or 2 days later, we are also ready to go, whenever they receive the meds, et cetera. So typically that's the first appointment. And if we send in, so a lot of the time we work with organizations like Chick Mission or Livestrong, Heartbeat, by Ferring, to get the cycle covered if they don't have insurance to cover the cycle, as well as get medications covered. And once all of that is done, so once they receive their meds and we've gotten the all clear to move forward, which is usually within 24 to 72 hours, we can go ahead and start the actual egg freezing cycle or embryo freezing cycle.
So you start all of that before the cancer treatment starts, is that correct?
Yeah, usually within a couple of days of seeing us, they're able to start their shots, because the cycle itself, it's 10 to 14 days of shots and then an egg retrieval. So usually from when they see us to when they have their retrieval, we're typically able to do that in 2 weeks. I would say at most 3 weeks, as long as it's permittable based on their plan for cancer treatment.
So I myself went through 3 rounds of IVF. This bring back such memories. So, but I have a question. As I went through the 3 rounds, how do you handle when someone, if egg retrieval doesn't go well, I've got to go again, their treatment's coming up?
It really depends. In some cases, unfortunately, we don't have the luxury of doing multiple rounds of egg freezing, depending on the stage of their cancer, and the plan. With breast cancer specifically, a lot of the time, patients will have surgery for breast cancer. Then they have a period of time when they can undergo egg freezing, and then they start chemotherapy.
Okay.
And so in some of those patients, we are able to fit in 2 cycles if we need to.
Okay.
The important thing to note is when you do a traditional IVF cycle, we have the luxury of doing multiple protocols that usually may involve priming the ovaries before starting medications. With a cancer patient, we start the medications wherever they are in their cycle. And so that's called a random start protocol. And we have data showing that this does not decrease the outcomes from an egg freezing cycle. And so that's why we're able to move much more quickly with an oncofertility patient than with someone who was coming to do IVF for the purposes of embryo freezing or, growing their family. So let's say we do 10 days of medications. We do the first retrieval 2 days after that. So that's 12 days. And their oncofertility, their oncologist says we are able to do another cycle. Maybe if we have, they can give us another 2 weeks. Then usually a few days after that first cycle, we're able to start another set of meds.
Okay.
And then do another retrieval. We will not be waiting 2 weeks and waiting for another period. Like we would go back to back right away.
Okay.
If that
And
was
that's where
what we're trying to achieve.
And that's where you come in. So just let's stress about this because you are a specialist in this arena, right? You truly understand the whole cancer fertility, the whole timelines, as opposed to just a regular, I hate to say regular, but a fertility specialist that just is just doing infertility. Is that correct? Both of you are really specializing in this. Is that right?
I would say that's the case, but I don't want anyone to feel like if they are in a place, like Lali said, some places may not have a fertility clinic that sees a lot of oncofertility patients. And I don't want a patient to feel like they can't freeze their eggs at their local clinic because that clinic may not advertise itself as being, an oncofertility center or doing a lot of egg freezing cycles. What's most important is your fertility doctor being in close communication with your oncologist and understanding your treatment plan, what is feasible within the treatment plan, explaining to your oncologist what is feasible from a fertility perspective, and also learning from the oncologist what is feasible from an oncology perspective, because it's really a team effort to try to get the most out of any given cycle.
I agree. And it's mostly about the urgency as well. Like we understand that when it's an oncofertility patient, there is no time versus a non-onco fertility patient, you have a little bit more time.
Let's talk about that because these medications. So what medications in the breast cancer treatment, world of what we have to take, why and what are they that cause problems with fertility?
Dr. Kina alluded to it. Chemotherapy, for example, we have a lot more research that shows that can damage your ovaries. I think as we get more and more targeted treatments, we are seeing that maybe some of those aren't as damaging to fertility. I still think it's important to have that conversation. Again, we just don't know what that treatment's going to look like. But we also have a ton more research now, even with the hormone therapies, with the aromatase inhibitors, that we can actually stop the treatment and let patients get pregnant. So because we're getting such good data, I think it's, again, critical that we do the fertility preservation before treatment with that hope that that patient will eventually be able to get pregnant, even if we do have to stop their hormone therapy, for example, for a few months while they're pregnant, et cetera. It's really just about getting more and more research.
And why can't someone take their hormone therapy during pregnancy? What happens?
So, I don't know if you want to take it as well, or so with the hormone therapies for breast cancer, there are basically two groups. One group are the aromatase inhibitors, and then the other group of medications are things like tamoxifen, which are selective estrogen receptor modulators. And both of these medications affect either the production of estrogen or the way that the body perceives estrogen. And estrogen is a hormone that is important for both getting pregnant and staying pregnant. And so you cannot concurrently be on these medications while you're trying to get pregnant because you actually stop ovulating while you're on these medications. And of course, in pregnancy, when you need estrogen to be present, you cannot continue on these medications. Also not factoring in that these medications would probably cause like birth defects if you were to stay on them in pregnancy. So we just don't keep patients on these medications during pregnancy. I want to clarify though, that when patients with breast cancer go through fertility treatments, we do put them on aromatase inhibitors for the purposes of keeping their estrogen levels low. And that is safe to do because I don't want to create the impression that they are unsafe while you're trying to freeze your eggs. They are recommended while freezing your eggs for breast cancer, but they are not recommended if you're pregnant or actively trying to get pregnant, as in post-ovulation and trying to get pregnant.
So you can take them while you're going through the cycle, but then when you're pregnant, you should not take them at all.
Exactly.
How about afterwards? I mean, you get back on
So you
away?
can get back them after pregnancy. The other thing to keep in mind is a lot of women get diagnosed with breast cancer either in their 30s or early 40s. And at this point in time, fertility is already compromised, especially in your late 30s to early 40s. And so if you were going to go through menopause, let's say at age 50, which means that your fertility potential probably would be significantly reduced by age 43, 44, even with IVF, without going through chemotherapy. But then you got diagnosed with breast cancer at age 30 and went through chemo, which the chemotherapy, like Lali mentioned, decreases your egg count now or has already brought your date of menopause closer, right? And then you have to be on tamoxifen or letrozole for 5 years or 10 years, now you're going to be way out of your fertility window by the time you're done with treatment. So at that point in time, conceiving with your own eggs will not be an option. And so the reason that we would recommend ideally freezing eggs before starting chemo is because when you freeze your eggs before chemo, you're able to get eggs before they're even exposed to chemo, so you can get more eggs from an egg retrieval cycle. And then you can, if you choose, complete the chemo and the hormonal therapy, and then decide to go through IVF with the eggs you have previously frozen. Or like Lali said, you can start your hormonal therapy and then take a break, get pregnant, and then resume your hormonal therapy after that.
Wow, it's a lot to take in. You know, you hear the words, you've got breast cancer, and even I know all about this, and I'm listening, and my head's spinning, and I'm sitting here thinking, what about? I know the cost of IVF is extreme, or fertility is very expensive. You know, the resources. Lali, can you talk about that? Like, as far as what, you know, what you do within your organization and how you can help people understand this and also be by their side with your specialty pharmacists that are trained in oncology, right?
Sure. Yeah. I mean, I talk about another significant barrier. So again, here's another space where we are getting better. So I think as the last time I checked, I think it was something around like 28 states now have legislation that does cover fertility preservation for patients that have a cancer diagnosis. But even that, sometimes there's a lot of caveats to that. There's a lot of loopholes. So not all patients may have coverage. So that's why we were mentioning like Chick Mission, Worth the Wait. Those are organizations that can sometimes help support, pay for the treatment, for the medical treatment. And then for the drug treatment, we have different programs. So Fairing Heartbeat was mentioned. We also have Reunite Onco. And so those are organizations or pharma manufacturers that will pay for the cost of the medications for cancer patients. And typically, again, we kind of, as a specialty pharmacist, when I see it's an oncofertility, we try to get it out in 24 hours because we know that we need it in a timely manner. And typically with those programs, we just need a form from the oncologist, so sort of stating that the treatment is going to be gonatotoxic. And then we need a treatment plan from the fertility specialist. And once we have those documentations, then usually patients get approved pretty quickly.
And so what you, sorry, did you have to?
No, I was just going to say, like, it is, you know, there's hope, but a lot of times, you know, we do need this additional support because it is very expensive.
And can you explain where a specialty pharmacist comes into play as opposed to just a regular pharmacist and how they can help in the world of oncology? And
yeah, so I always, you know, as a specialty pharmacist, I always have to do the need for them. But at my pharmacy, what we do, we sort of have a last catch-all. So any new to therapy patient that is going to go on a gonatotoxic treatment, we ask them if they did have a fertility preservation conversation. Now, ideally, this had already happened at the oncologist office. So we're hoping to just catch very few people. But the last time we presented research on this, we still had about 20% of patients that still had no idea that fertility preservation was something that they need to address. And so typically we will ask them that question. If they say, yes, I'm interested, then we do refer them to a same-day telehealth consult with a fertility clinic. And so that's a role that specialty pharmacy is sort of helping to close the gap on these conversations. But really, it can happen even after the treatment. So even if maybe the patient wasn't interested and then went through cancer treatment and now is. So I still think there's a place for specialty pharmacy to continue to educate patients. We do have patients that do get pregnant even after treatment. So, you know, I just want that hope to still be there. But those are two spots where I think specialty pharmacy can play a role.
so I'd like to ask both of you, as I'm listening to you, you're both like, to me, you're like all the way down the line in the world of, I have breast cancer. What's HER2 positive? What's HER2 negative? What's ER positive? Oh my gosh, I need a what? A lumpectomy, maybe a mastectomy, and I have a tumor the size of a walnut. How do we process emotionally and also get to the young patients? Kind of a double question here. You know, young patients. I obviously was 52 when I was diagnosed. It wasn't a concern to me to worry about fertility, but how, in your mind, because you guys are over here at the beginning stages, if you could say something to any newly diagnosed patient in their 20s or 30s, because we'll share with you that the medical advisors, a lot of the breast surgeons on the Learn Look Locate medical advisory team are telling me that they are seeing such a high rise in numbers of the women in their 20s and 30s. This conversation is so very important. So I'm just curious what you guys think. What would you like to say if you were able to scream at the top of a rooftop to people in their 20s and 30s? Dr. Kina?
Yeah, and are you talking about patients who have been recently diagnosed and what I would recommend?
Just heard the words. I just got diagnosed. I'm 25 years old. I'm 30. And what would you like to say in just patient-friendly terms, in an emotional way that they can process?
So what I would say is breast cancer these days is one of the most treatable kinds of cancer. And so there is every reason for them to hope that, they will be hopefully very soon on the other end of that journey. And the reason that they're seeing me is because there is hope that they're going to be on the end of that journey. And so my role is to make sure that they understand all the options available to them so that they're able to, when they get to that other side, build the life that they want to build, that they've always dreamed of, and know that they don't have to let go of that dream because of what they're currently going through.
To be able to build a family, right?
Mm-hmm. Yeah. And I always tell, one of the things I say to a lot of my patients, irrespective of what's going on, is to think about what's the next thing I have to do. It's so overwhelming when you think of trying to do every single thing, wrap your head around every single part of the process. We're talking about, hormone therapy in 5 years and 10, like that is just so overwhelming to think about when you're just trying to figure out what appointments do you have in the next 24 hours. And so I tell them, how do you eat an elephant? One bite at a time. What's the next thing you need to do? And then the next thing you need to do. And then the next thing you need to do. And it sounds a little bit, sometimes it might sound a little crazy to say that, but when you start to think about it that way, and that's something I learned from my own experience in life, is that when you start to think about, okay, I'm just going to do the next thing, and then I'll do the next thing. And very soon you're making progress along your journey.
But there is a sense of urgency within this part of their journey if you're in your 20s and 30s. So we really need to stress that. Yeah,
and even with the sense of urgency, I still think it's important to just do the next thing. I don't think you need to figure out what's going to happen when I get my meds, what's the first thing you need to do? You need to show up for your first appointment. Okay, and then you're going to do blood work. And then we're going to send you a link of the medications and how to take them. And then you're going to receive the medications. And I think if you just focus on then the next thing, then the next thing, and of course, knowing that we are always there with you every step of the way. So if something doesn't make sense, if something is unclear, you can always reach out. Your fertility team is there for you, of course. Your oncology team is there for you. Your pharmacy team is there for you. So just knowing that, there is this safety net under you. And as long as you're just taking the next step and then the next step and then the next step, if there are any roadblocks or concerns along the way, there are people there who are rooting for you, whose focus is helping you be successful on your journey.
And the side effects from the medication, and Lolly, I want to hear your answer, but I just have a quick question about the side effects from the medication for fertility preservation. I remember them. Can we just touch on that really quick? Because there are some.
Yeah, for sure. So, when you're taking these medications, they are increasing your levels of estrogen. And even when you're on a medicine like letrozole, which is going to keep your estrogen levels low, you're still going to have the effects of high estrogen levels, which are, first of all, bloating and distension as your ovaries are getting larger. You may feel more emotional or irritable or weepy, which is compounded by, of course, what you're going through, which is very emotional to begin with. You may feel more tired or fatigued. Some of my patients report having a little bit of difficulty sleeping because they're so uncomfortable from the bloating. Because you're giving yourself these medications or shots, there might be some bruising on your belly. The important thing to know is that these side effects, the meds you're on for about, let's say, 10 to 12 days, side effects usually don't kick in until around day 5, and they usually resolve shortly after your egg retrieval. So you're not going to feel like this for a long period of time or for forever. And there's some patients who have no side effects as well. So I have patients who say, oh, I was expecting to feel horrible, and I'd watched all these videos on YouTube because, YouTube is always sensational. If not, no one's going to watch it. So you have to be sensational. So nothing against YouTube. And so they're like, oh, I'm surprised that I feel fine. And so I don't want you to assume that everybody who goes through egg freezing will feel awful, but some people may not feel their best while they're going through the process. I do tend to stress the emotional side effects in my patients who are already going through a difficult time, because it can bring, when you combine the emotional side effects with what you're going through, it can be overwhelming. So I think it's important to have a support structure in place, whether that's your family or your therapist or somebody that you can touch base with as you go through this process.
Molly, any thoughts on this?
I agree. I think as a pharmacist, half my job obviously is counseling on side effects and things like that, but the other is just providing hope. I used to say I don't do direct patient care anymore, but before, like, I had 30 seconds to decide about the patient in front of me wanted to hear, I've been through this too. Like, I know what you're going through, or nope, you're the first person you're the only one going through this, right? Like, there's almost like those two types of patients. And so I kind of have to manage what it is that they want to hear. What do they need in that moment? Sometimes they do need something more than we can provide. And so we have support groups. So Resolve has support groups that they can even do virtual ones. There are even some specific through Cancer Buddy is a great organization where they pair people up like in Cancer Buddies or mentors with Ironman Angels, someone that's going through exactly what they're going through. Again, if that patient wants to hear they're not alone versus the patient that wants to feel like solely supported, like this is, woe is me, and like we're here for you. So that's sort of how I see my counseling, just really very personalized, depending on what that patient's going through, what their diagnosis is, what the prognosis is, and even if, how they feel about motherhood. Like, some patients are just doing it for insurance and they're not sure yet, and that's great. Some patients, that's all they want, and they would rather forego cancer treatment, right, to do this. And so there's really just a myriad of patients, and you really have to counsel the patient in front of you very personally.
I think one thing I want to address is I went through 3 rounds. 2 of those did not take. And the emotional side of it not taking is really hard. I remember it distinctly. And at the 3rd round, I was like, I can't do this again. It's a lot.
I think that's probably the hardest, right? Like, this is not like an insurance policy. Like, at the end of the day, this may not work. And so I think that's a really hard conversation to just, and that's something that I think is really important, providing that hope. Like, there's so many ways to become a mom or a dad. If that's ultimately your goal, it may not be how you originally thought it was going to be, but there are other ways. And so making sure that that patient understands, if this doesn't work, there's still ways to do that.
That's nice. Thank you. I know we don't have a lot of time, so I wanted to make sure that if you have any other closing thoughts, I have a whole list of questions here, but we're a little short on time, but I do want to stress how important this topic is and how lucky we are to have both of you, because really trying to bridge that gap for not only patients here in the US, but globally, to understand this part of the journey, especially for young patients who are facing so much at once. The diagnosis is hard enough. So any closing thoughts, guys?
One other thing I wanted to talk about, because a lot of patients come to me thinking that the egg retrieval is going to be this overwhelming process. Sometimes with breast cancer, they've already had their breast cancer surgery. And so they're thinking this is going to be another major surgery that they have to recover from. And then they're going to go into chemo. So I like to stress, in addition to it being only 10 to 14 days of medications, the egg retrieval is a 20 to 30-minute procedure. And it's all done vaginally. And the needle we use is like a blood draw. So the level of impact that you would expect vaginally would be similar to if you got your blood drawn and it heals right away. And, most of the time, the day after the retrieval, for most patients, the biggest side effect is that they're still tired and groggy from the retrieval, and they feel bloated and maybe constipated. But they're able to go about their day. They're able to go to the grocery store. And so I like to help them understand that this is not another major surgery that you're going to have. This is going to be a simple, short procedure, and that you should be able to then recover in time before you have to start chemotherapy, if that's the plan.
So helpful. Thank you for sharing that. One less stress, right?
Yeah, exactly.
Lolly, any last thoughts?
Yeah, my closing thought is, I'm sure a lot of your viewers may already be sort of post-diagnosis, and I think we've talked a lot about the importance of getting fertility treatment before diagnosis, but I just want to stress that, again, that doesn't mean that there isn't something we can do after treatment. And so if you do have some viewers that already went through treatment and are thinking, oh gosh, my time's up, like, that's not necessarily the case. So still reach out, still seek a fertility consult, because there's still a lot that we can do.
Yeah, and we're going to work hard at getting that message out as part of bringing this resource forward, is to really enforce and make people aware and have these conversations with their oncologists. I will share with you one of the reasons why I started Learn Look Locate is to not only empower myself, but empower others about so much that in that short window of time when we meet with our breast surgeon, it's not brought up. And so if for some reason this is not brought up for anyone newly diagnosed that wants to have a family, we want to make sure that you have the right questions to ask your oncology team to bring forward in the world of fertility, because this is really, really important. So we are so grateful, guys. Thank you so much for this incredible interview. I hope it reaches a lot of people. So thank you both.
Thank you for
what you
having
do
me.
today.
Exactly, and for having this incredible organization. And I feel like it's helping so many people, so many more than you probably even realize, honestly. So thank you.